Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
Movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro in, I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today, we're in the middle of our New Jersey loop. We'll put it that way. So we just got done teaching DNS course here, Brett, and we called on one of our good buddies, Dr. David Graeber. So, Dave, I met you through a Facebook group. I met you through a couple conferences that I've seen you teach. You kind of got your name, I guess, for being one of the few people. I put Brett in the same category that actually reads research and then knows how to distill bullshit from things that are going to change your practice. And so today we're going to kind of I want to dive into that of how do we actually use research in our day-to-day practice? Maybe it doesn't matter. How do you actually apply the stuff that are getting written in these articles?
Okay, it's a good question. You don't.
Yeah.
Pretty much, or the most profession. Actually, I put out a blog, and we put out an article on that, and they said, well, practitioners, should we read research? And the answer is mostly no. Most practitioners are too busy taking care of people, real problems in real life, and research doesn't necessarily reflect a lot of that. Now, researchers get upset about that, but in truth, that's what we have to do. You have to parse out things to make it, controlled, clinical, and practice anything but controlled. So I always recommend people don't read the research. You want to read a systematic review, find someone who knows how to read research and knows how to interpret it and do that. And use a guideline. But the last thing you want to do is read a research paper, because I've seen chiropractors quote research all the time, and they quote it wrong. It's how did you get that conclusion? That wasn't what the article said.
Well, because you read the abstract and the conclusion, and then you're good to go, right?
Right, exactly. And what's worse was when COVID hit, there's a lot of colleagues, I don't know about where you guys were, but a lot of colleagues who started making comments on COVID and a wide variety of health topics and quoting research. And I said, you're interpreting statistics. How many biostatistics courses have you had? I've had none, have you? And they're like, no, but, so you're going by what somebody else said. So now what camp are you going to fall into? And I think that happens a lot in the chiropractic world.
Sure.
So we're practitioners. We're supposed to take research and put it into practice. And that's only one source of data. And I think what's happened a lot in the profession is that evidence-based. And so I think, I know some practitioners who won't do anything unless there's a study about it. And this profession would never get anywhere if that was the case.
Yeah, it's would be 20 years behind all the time.
Yeah.
Well, you wouldn't do anything with your patients.
No. So, the model I use, and you guys take out your left hand, there's a reason why we'll do this. So, let's say these are data sources. So, with your thumb, this is research. This is clinical research, and we all know that. There's a hierarchy of evidence. You got systematic reviews and RCTs and, observational studies, case control, yada, yada, down the line. And that's one thing. Then you have outcomes. This is basically feedback and tracking, and that's most of what we use. You find a measure where you could actually do some feedback and tracking, like I have a Fitbit, and this gives me data, and I can track, and I can look at patterns, and I can make predictions with that. So that's the second way. So you have feedback and tracking. Then third is experience, observation, what you see, what the euphemism now is called anecdata, where you take that kind of data that you're getting for observational. The ring finger, we'll call that anecdotes. These are stories, narratives that we have, theories that we have. And this is basically stuff we've accepted on trust. So just like if Brett told me something and said, I said, Brett, how do you handle patients with migraine headaches? He would tell me, oh, I found this pattern. And now, does he have any research about that? No, he didn't research about that. Maybe he's done some tracking, but I trust him. So I say, okay, I'm going to trust him as a trusted source, and that would be my anecdote. That would be this, and finally this would be a reasoning, reasoning. Deductive, inductive, abductive, analogical reasoning. Now I put these in this particular left hand because the ring finger, you guys, okay, good, you're married?
Yeah, married.
Oh, cool. Okay. So on our left, we all have it. So we get married to our stories, get married to our anecdotes, get married to our theories. Oh, good. The audience is also there. Nice to know we're doing this in front of a live audience, by the way.
Right. Yeah.
And you don't take this off, right? Because you don't want to divorce yourself. And a lot of times we don't want to divorce ourselves.
Taylor only takes his off at a bar.
Yeah, that's right.
Really? Okay. I'm glad you didn't take this off.
That's my dad's famous joke. I can only get my wedding ring off at a bar.
But you can take it off. You don't have to be married to your theories. And I usually, this is the middle finger, and I'm going to hold it up this way because if I turn it around and just show
you can say it to the camera. It's okay.
You have no idea.
Yeah, that's right.
Okay,
yeah, we're in
good.
Jersey.
We go completely New Jersey. Jersey, by the way.
Jersey.
Pronounce it right. But basically, yeah, they're just going to go by their middle finger, basically, and say, that's it. I believe this. I've seen it, so it's true. And so, but these are all 5 ways of getting the data sets and information, and that's how you make a clinical judgment. You don't just go by research. Yeah, I love a good RCT when it shows something. That's generalizable, but how do you make it specific for a patient? Well, you'd use outcomes. Otherwise, if you just use your experience, you might be fooling yourself with that. And yeah, sometimes you don't even know what to do. And so, well, Brett said this, so I'm going to try that, and you go by that. And sometimes you just got to use reasoning and just try to figure it out with that.
One thing people might not know about you, you're an amazing dynamic palpator and manipulator. So what do you think, so when the evidence is, well, they say the evidence is telling us there's no reliability in palpation and things like that, which those of us who've been doing it forever, we know that's so intuitively wrong when people say that because there's so much we can learn from palpation. So when the evidence-based people are telling us there's no reliability with palpation, I mean, what do you say to that?
The answer to that? Yeah. Well, first of all, it's not, quote, the evidence-based community says that. I mean, the evidence-based community is, there are those who say there is reason to use it. Others who say no, it actually should kind of be discarded. But if you get deep down into it, nobody's ever saying palpation doesn't work. Very few, I should say, do that. I mean, they say how you're going to use it. They say, well, you can't really palpate motion. You can't. We all know alignment. Forget that. I was hopefully that we passed by that part, but it's not for a good section of the profession.
We're not realigning spines?
Yeah, exactly. We're not taking this bone and moving it a millimeter left, millimeter, that type of stuff. But motion, can you palpate it just like mental motion? We know it's not as specific as we'd like. True. And then there's provocative testing. We assess the pain response to when you actually stress test a joint, and that's got a good degree of reliability. Okay, well, so what if you took it all together, put it together? And you take, okay, I've got motion findings, palpation, I'll put that with provocative testing, and match that with their symptom picture. Then you get a very accurate most times, idea of what's going on with the patient and how best to help them. And to get an idea predicting, okay, this could actually work with this person, this will not. And we know that by experience. So we go through here, and then you do your own feedback and tracking and see how that works, and you know it. And
it's kind of like clustering orthopedic tests. Like one orthopedic test may have good sensitivity and specificity, but you're clustering together your multiple different findings to come to a conclusion that you're going to do an intervention.
Exactly. Clinical prediction rules, kind of the new fancy term for that.
Right, exactly.
So it's interesting though, on the pain provocation thing, I think sometimes we got to be careful with that because would you agree that a hypermobile joint could also potentially create a symptomatic response when provoked?
Yeah.
And a restricted joint. So, and the only reason I say that is I like the idea that we're coupling multiple things together, but I always think of Laszlo's criteria. And when, he actually, I've heard him say this where, if you're dealing with the postpartum female who actually has, we'll say a 4 out of 5, on a Laszlo criteria, that usually that is going to be the hypermobile SI joint, postpartum female, things like that. It's actually the Laszlo cluster is actually not good at telling us which SI joint is restricted and that we need to manipulate. So I think provocation tests are very helpful and they're great, but they don't tell the whole story when coupled with joint play. And I think if you look at the research on joint play, actually, even if you take people who aren't even trained in joint play, they actually are relatively good at finding massive areas of the spine that aren't moving well. And actually that was Lin Fei's original model, which was those are our primary fixations. So as you get better at this, then you're actually able to find the nuances in these other areas that aren't so obvious. But even if you're a complete buffoon, you can still put your hands on someone's back and realize this block of vertebrae is not moving very well. And if you manipulate and mobilize those areas, you're probably gonna have a decent outcome.
Right.
So I think it's like the coupling of the provocation test with good joint play. And one thing I've learned in the last 10 years about teaching is the thing that I think people are not doing well when you joint play, you've got to get that segment to end range.
Yes.
In the story I always tell about myself, I was teaching at Logan and my students, they had them in a seated scan position and the students are like, I don't feel anything. And what I realized was what they were doing, they had the SI joint at mid-range, so they had the patient like this, and they're just like jiggling the joint. Yeah. And then I'm like, well, that's not what I'm doing. So I was teaching it, but then I was doing what allows you to be able to feel it, but I wasn't teaching it well. So then I realized myself, I'm doing a good job at taking the motion out and then springing it. And I think that I had a good conversation with Lynn recently about this. I think this is the secret to palpation that people don't realize. Like they're trying to spring joints in mid-range instead of in range. In range and whatever motion or plane you're trying to palpate, then it kind of jumps out at you.
Yes. Yeah. No, you're exactly right. You're exactly right. I mean, I like what you hear. The whole term here is nuance.
Right.
So you learn what works for you and how your style of doing it. Now, intra, where examiner reliability is pretty good with motion palpation. So you could palpate Taylor and several times you get the same result. We might differ. Inter-examiner reliability may not be there, but you actually can do that with him. And patients are, an N of one, basically. Every patient is an N of one. I mean, they're all unique. They have a unique set of factors. And you've got to actually apply that, put that into that.
But even like in inner reliability, they did this study a couple years ago on orthopedic surgeons. And basically, if the orthopedic surgeon, the shoulder orthopedic surgeon, looked at an MRI, even within themselves, they looked at the same MRI 3 weeks later, some of them had like a different interpretation of the same thing. And I feel like the rest of the world gets a pass, and then like for chiropractors, for some reason, like it's like,
see, you guys aren't doing it.
You're not reliable.
No, that's not good. That's not good.
Right.
So so I mean, that's kind of frustrating.
And I think the same thing would maybe apply to manipulation. I think the nuance in manipulation is something that you guys could talk about a lot. I'm only 5 years in practice, so I think nuance in manipulation is something that doesn't get talked about a lot. You may do something very minutely different, and you're an expert in manipulation. You're known around the world for manipulation. So can you maybe talk about like developing that feel for nuance? How did you do it? What are some of the things that made you successful over the years that like have made you to the point now that you can kind of walk in and make those nuance changes that maybe someone in the room would never notice that you're doing? Right.
Yeah, that's actually a really, really good point. I mean, what I tell people, students, when you graduate school, you graduate as a good beginner. You get a degree, and you now can enter the field. But it's all about practice. It's all about practice. I mean, when I got out of school, I did a lot of office coverage, and I would see some practice 20 patients a day, some practice 100 patients a day. And if you've ever seen like high volume, there's no really time to think. You've got to like feel and do and move on, and you get very good very quickly, or else you're just not going to do that. And so, practice. If students graduate school think they've got it. They've got the basic tools to enter, the real world. You got a degree. You graduate with a degree in your field. Well, guess what? You're now a freshman in practice, and now you've got to actually develop the skills, get your bachelor's in practice, which is probably where you're at, or even a master's degree because you're hanging out with this guy, getting trained and tutored.
That's a downgrade.
It's all nuance. Remember, it's all nuance.
What about maybe? Can I re-ask the question? Are there certain things throughout your day of seeing patients that? Like Brett always talks about, he reflects on his patients at the end of the day, or he'll see patterns better than most people. What are some of the things like intangibles that you maybe have that are, I'm trying to ask of like, what are the little things throughout your day that you're doing that are making you better every single patient?
Well, pre and post, definitely pre and post checks, and always looking out for, it escaped me before, what are they called? The zebra. The ones that, everything should have went this way, but it didn't. What happened here? what happened here? Is this just a fluke, or am I missing something? Because that's your doorway to learning something new. You thought it would go this way, it went this way. Well, why did it go that way? Is that just one of those things? Is it an outlier, or it is, oh, you know what? I got a blind spot. I just realized this is something else, something new to learn. But one thing that is important is actually getting together and with other practitioners, not just to adjust each other. Because I mean, when I teach a technique seminar, there's a couple of criteria I have where it's successful. One of the things is I learned something. I learned something new. And sometimes, everyone's like intimidated. Show me what you do in your office. And I don't want to show you because they think I'm going to be, critique them. And it's like, no, school's over. This is post-grad. You're in the real world, taking care of real patients in real time. You're my colleague. I respect you. What are you doing? I'll help you do it better, but show me what you're doing. And invariably, somebody does something where they have no idea what they're doing. And I'm like, that was brilliant. That was brilliant. And you learn and get critique from your other colleagues. And we don't like to do that. We
It's
don't
uncomfortable.
Like to do that. Yeah. It's kind of like when you get together and no one wants to, in a technique, I always say there's 3 rings in any technique class. There's people are there for credits. They're just here. Okay.
Paper in the back. And
yeah, the CEO, it's like, okay, oh, Brett, I haven't seen you in school. Okay, you guys go in the back, go catch up, keep your voice down, don't disturb anybody. And the colleges don't like, I say, just leave the room, go get coffee, but you got to be in the room to get your credits. Then there's the ones who want to learn, but they don't want to show what they know or don't know. They're kind of embarrassed. So they kind of like get like that inner ring. And then you have the ones who are like, no, I'm all in, show me. And they want to work together and they want you to go hands-on and show them with that. And the second group, that second ring of people, that's very prominent because it's like, okay, you practice next town over to me and you practice over here and, oh, wow, I don't want you guys to see if I'm not as good as you guys think I am. Sure. There's a lot of ego in our profession around that. They don't have it in medicine because they kind of beat it out of you. I mean, you go through grand rounds and it's like, Taylor, what'd you do with this patient? Why'd you do that? Why didn't you do this? What made you think that? And you're like, yeah, they grill you to actually, stand up for yourself. Sure. And they know how to do that. Our profession, it's like, why'd you do that? What I mean, we are so craving validity because, we're basically, like you said, like why we don't get a pass, right? We don't get a pass from outside, but I think inside we also don't get a pass.
Right.
And then it becomes like kind of more image and you lose some of the content. So how do you get better? First, you get humble. I watch, if I watch you adjust someone, I'm going, wow, how did you do that? Well, you have a different body type than I do. So you got different leverage points. Same with you. Now experience and different, gender comes into it. Women have to adjust differently than men. It's, tall is different than short. Sure. And then shape. Some people have wonderful psychomotor skills, and others, we got to actually help them get by. It's like, go by a Leandro table, use a lot of distraction, some people. Okay, if we're being honest. It's okay, we have a lot of ways of helping patients. Using hands-on manipulation, manual therapy, and all kinds of things with that. Right. You got to find your niche, but you got to work it, and it's daily practice to get better and better. And that's true in any profession, any skill, any craft. Now, we don't have a structured way of doing it. We graduate and we get let loose, into the world, into the public, and we have to basically learn by doing. And it's kind of growing up in public. Unless there's a situation, you have a great situation, and you can have some mentorship. Very rare in our profession. Mm-hmm.
Yeah.
I think you're led to believe too, like if you're in school though, like if you can adjust your patient well, that everybody's going to get better. And like the dirty little secret that's not told to you, just because you can rattle off and bang joints doesn't necessarily mean the patient's going to come back and tell you that they're better. So that's what's difficult with dealing with humans. There's more to getting people better than just being able to, manipulate a joint well. And I think people go through chiropractic college and they don't really understand like what it actually takes to manage a case. So there's everything it takes that you're talking about to be successful clinically. And then we have what we call like the soft sides of clinical success, which is empathy, confidence, certainty, coaching, whatever you want. Right. What do you think your gold medal is besides being great at adjusting? Like, what do you think that you do well with the patient outside of the clinical side that's made you successful?
Good question. Okay. By the way, good questions. I've been asked that before. I think that I've developed a very good way of actually getting rapport with patients. And I mean, I teach there's 5 things to get into getting your results. One is natural history. You want to work with the natural history of a condition rather than work against it. Patient expectations and their conditioning, what they expect in their minds. You got to find out what it is. What do they need to hear? What do they need to see? treatment ritual, having it structured so they actually know what to expect, then the general effects of what you're doing and the specific effects of what you're doing. Now, and that's up here. I mean, you could get half the results I think we get basically are by working with natural history, working with the patient's expectation, their concepts, their conditioning, and having a structured treatment that they actually feel like they're actually in the right place. And if they feel they're in the right place, they tend to get better faster than if they don't feel that.
You talked about rapport. It's interesting. I've been having to do a couple of presentations on this. So the rapport is established in the 15 seconds of you being, not just in our field, but like in doctoring in general. So rapport in the first 15 seconds is established, good or bad. And then the other thing, 93% of rapport is nonverbal, which I think is insane. It's not what you're saying. It's like, do you have a smile on your face? What do you look empathetic? Are you look like you'd rather be somewhere else? That is insane to me. 93% is nonverbal in rapport, and like rapport is one of the most important things that you can do like early on. And then I always say the other R is reassurance, which I'm sure you're great at without even realizing it, which is what the patient really wants to know, especially in the world of chiropractic where we're kind of the low men on the totem pole. Am I in the right place? Do I have your next steps? And I think because like if let's say they have a disc herniation, in the back of their mind, what they may be thinking is, do I need an MRI? Do I need an orthopedic surgeon? Do I need, and if you can let them know, like you can reassure them that they're going to be okay, and you can reassure them that like, even if we're not able to help you at this very moment, we have your next steps. I think great clinicians are really good at offering and kind of sowing reassurance. And I feel like since we're all in this evidence-based circle, the evidence-based chiros, they go through their day without a bunch of miracles just because they're questioning everything themselves.
Right.
And like that jackass down the street who knows nothing, they can get miracle after miracle just because they're bought into what they're selling. It might be wrong, but like they're exuding certainty and confidence. So like in our evidence-based circles, it's almost like we need to get them as excited about what we'd argue would be like right. And then that way they're better at selling their what, you know, and I think like patients actually really do pick up on that. And like James Andrews, the best orthopedic surgeon in the world, I mean, he basically, we were wanting to talk about surgery. He just kept going back to what we're talking about right now, like just like what it takes to be a great clinician. You got to care, you got to offer reassurance, and
If we to summarize what you said, we can do that one word: presence.
Good point.
When you show up, you speak volumes. Can I tell you a story? My son needed open heart surgery. We found out he had a heart murmur. He had an atrial septal defect. Found it 9 months, and that's the whole of the story about everything we tried through the whole world of holistic and natural healing to try to get it. Finally, we found out he needs surgery. So we started interviewing surgeons. So we went to New York City. One of the ones we went to was Columbia, and there was a guy, Dr. Quaggabar, and he was widely known. He flew off to Saudi Arabia, did the open heart surgery on their kids. He did the worst of the worst. He takes care of. So we went to see him, but sometimes you can't get him, so you get his associates. So my son he's 3 years old, and he's walking around the room, and we're interviewing with the associate surgeon, and nice guy, could tell he was competent. We got done. My wife said, "What do you think?" I said, "I think he's good. I think he's good. Fine." Later on that day, we got an interview with Dr. Quaggabar, and we sit in here, and the presence he had in his room was like, "I am here." He sat down. My son, he sat up like that. At 3 years old, he picked up on the presence. And he's just going very bad. Well, he has this is very, from my end as a surgeon, it's actually a very simple, very straightforward procedure, yada, yada. And then my wife asked him the question. She goes, "What if something goes wrong in the operating room?" And he stopped. He gave a look. I cannot duplicate it here, but that look was almost like he was going to come across the table at her, and it just came through him, and he just said, "That doesn't happen in my OR." And I looked at him, and in that moment, we chose our surgeon. But Wes, what do you think? Let's make the appointment. No, nothing's going to go wrong. If anything goes wrong, this is the last guy who's going to have something go wrong. Now, did I know that? Did I look? Yeah, I know his credentials, knew everything about it. The other guy was excellent. We saw others, they were excellent. This guy had the presence. But he had the presence because he could do it. He was good, and he knew it. It was like, okay, what you're bringing up here, now, this is a really good point, which I want to go into, because the evidence-based crowd sometimes practices, and I hate to use the term evidence-based crowd, but
because we're in that group. I mean, we're not like talking outside.
we want meat. Yeah, we don't want fluff.
Yeah.
We want meat. But a lot of them practice with a little bit of disclaimers. A disclaimer is, that guy down the street, he basically, clinically, he's mediocre at best. All he's got, but he knows how to talk to patients. He's adopted whether he's faking it or he actually believes in what he's doing, and patients sense that, and he's busy. But we don't like what he does. We don't like that. And so he's like, I'm not that guy. I'm not them. I'm different. But it's almost like a disclaimer. But the thing that they get right, the vitalistic part of our profession gets right, is that they understand that whole presence point, what you mentioned. Yeah. They understand when you show up with a patient, you've got to own what it is that you do. You got to know it. And if you don't, you got to figure out how you can get there. And the best way to do it is to know by doing. Just get good. There is competent. Sid Williams. You ever Sid Williams?
Yeah, of course.
Okay.
Life.
Okay. I got one key thing he said. I never forgot.
Is that where you went?
No, I did not go to Life. No. That's another
you
story.
went into NYCC, didn't you?
I went to NYCC. Yeah, no, Sid Williams and Life, and I was actually head of the student ICA in school.
Subtle brag.
No. It's not a subtle brag, because I sat down with the vice president of NYCC, and he wanted to know what my philosophy is. While he sat there, he's from Jersey, sat there, put his gun holster up so I could see the gun on his ankle. Okay, and I was like going, okay, subtle intimidation, maybe. Not working, but because he wanted to know was I, quote, a big DE, or because there was the whole thing about New York and the DE, and which is out of Life. But he said, he goes, you have to get a point when you know that you know that you know. And I'm like going, okay, redundant, yes, but what is it? If you know you're competent, and you know that you know you're confident, but if you know that you know that you know, you have certainty, and certainty which radiates, that creates a presence. And when you have that, and you walk in, you say, Brett Winchett, I don't know who he is. I don't know what he knows, but he's a master at something. And they don't even know you. Or you say, I'm a chiropractor, and you go, yeah, I'm going to come see you. Do I know anything? No, but presence precedes you. And
what do you think about, like, if we could talk like these people in our circles to be as certain about their functional findings as an orthopedic surgeon is about their image findings?
Right.
So like the cardiologist you mentioned before, he obviously, there was some kind of imaging done, and he said to you guys with 100% certainty, I've seen this a million times before, I'm going to be able to help you, blah, blah, blah. Whereas like in our world, I feel like we do an assessment, but we don't explain the findings good enough to where there's enough buy-in from the patient.
Right.
And like if you tear your meniscus in your knee, go to the orthopedic surgeon, they say, you got a torn meniscus, we'll see you next week for surgery. You don't like think about it, but like the reason you get such good compliance is because there was so much confidence and certainty in the But like chiropractors and present day physical therapists, I think we struggle in being able to convey that to the patient if they could just almost mind fuck themselves to where the functional findings are just as important as the structural findings. And if they can convey that to the patient, you have a completely different compliance.
Yes. Yeah, I agree.
Yeah. So like that, yeah, I know. I mean,
part of the big difference is you're talking about hard findings and soft findings. Mm-hmm. And a surgeon's a hard outcome, right? You have a meniscus tear there, needs repair. It's a very pretty black and white. You can see it on an image. I mean, it's there.
Good point. Yeah.
We're basically, you have a dysfunctional pattern of movement. You have fixation. And we try to use these technical terms, and it's not like, well, what are you going to do? And it's not a one and done thing either.
Yeah. Good point.
So this is more, I mean, the other professions that have it, other types of therapies have it too. Physical therapy, occupational therapy, speech therapy, psychotherapy, these are more soft healing arts because they're functional and not structural. And that's just a different, how do you get confident in that? Well, you really have to own what it is you do.
Yeah.
And sometimes it gets difficult because even members of ill-respected professions go against what they're doing, say, well, it's really, everyone's looking for the hard findings rather than look at the patient. What about patient outcomes? How does the patient respond? And if there's not a hard findings on that, it's kind of looked at, okay, well, I guess it was all placebo or this. And no, it's not that. There's a whole genre of things that go on with it, and to use your term, Gestalt of what actually makes the results of the patient.
Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar, November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brent Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So thanks for taking the time to listen to this episode, and we can't wait to see you at Parker University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
Do you think, like the evidence-based group that we're in, do you think like sometimes we're guilty of under-treatment? I think we are. Like personally, I feel like a lot of people like in our that we teach, they're so trying to be careful that they don't get lumped into, oh, I had to keep seeing my chiropractor, because that's kind of our stigma. However, like to truly make functional changes, a lot of times it takes time to like do this, and like it's a serial set of events, meaning like what I do today is leading to what I'm doing tomorrow and 4 weeks from now. So do you think that's kind of a problem? Because I mean, I think like the present day student leaves the average chiropractic college thinking they're going to fix everything in 2 visits. And you might be able to change pain in a visit or 2, but you're probably not going to be changing function in a visit or 2.
Yeah, I 100% agree with you.
Yeah, and I think that's like kind of a false set of goods that's being sold to the students, in that like you got to be able to like convey to the patient why they're there, because if it's only pain, the second they're out of pain, they're gone,
It's a diagnostic dilemma that you're basically describing. When patients come in, triage them. I slot them into 3 categories: acute, recurrent, or chronic. Okay, and maybe it's acute exacerbation of a chronic, maybe it's recurrent. These are 3 different kinds of patients. Your acute patients, it might be one and done, 2 when they're through, 3 and set them free, 4 kick them out the door, that type of thing.
Nice bit, Jesus.
I mean, that's what we're talking about. That might be it. And then, but what do you do after that? And we'll talk, this whole thing like maintenance care. Well, maintenance has got a bad connotation because we've made it that way. Our profession's made it that way. We created our own problems. So, okay, so you don't have an acute, you have a recurrent. They came in, you treated them a half dozen times. I feel great, doc, they leave. 3 months later, they're back in. Same injury. Okay, treat them again, send them back out, and they're back in again. It's like, okay, hold the phone here. Okay, slow your roll. You keep coming in with the same thing. This is no longer acute. This is recurrent. We're no longer just going to take care of this acute episode. We're going to find out what's underlying this, what you're doing in your life, and what the dysfunction is in your body that actually keeps this recurring. And then we're going to put you on a program, a regular care to actually maintain this. Correct it as best you can and quote, maintain it. It's a maintenance care. It's regular care. And then there's chronics. And the truth about chronics don't get better. I remember Len Fay said that to me. I remember it's like chronics don't get better. I'm like, what? And he's the first person with chiropractic. What do you mean they don't get better? He's like, chronics don't get better. They have to be managed for life.
Yeah, they're managed.
They are managed for life. So when you look at a patient and you see they've got 3 discs which are down to about 1/3 of degeneration, and their muscle tone is completely off. They're fibrotic in a lot of areas. Their movement patterns are off. Well, they're going to need an ongoing, and they're not going to need 3 times a week for forever. Like, you get people in your area that have they come in. I went to a chiropractor, had a year, 6-month prepaid plans.
Yeah. I mean, on the other end of the spectrum, I mean, pure insanity.
Yeah, and they come back in, and I was like, how are you feeling? I saw the same problem. First of all, I want to know who stays with that for that long a time. And it's like, wait a minute, after like the second or third month, don't you realize that this may be not working? Did they do anything different? No, they just kept doing it. It's got to take time, that. Oh boy, we're getting real off of that.
We're off the rails.
Yeah, no, really. But if they're chronic, but then here's the problem with, I think, a lot of what you're talking about, a lot of the students coming out, they've got to really understand what chronicity is and present to them a program, and then have the internal fortitude, the confidence, and the certainty to say, no, this is what you need. Yeah, okay, we could do it in piecemeal. We could actually get you out of an acute episode, but you've got to confront them with the fact that this is a chronic condition. It didn't happen overnight. It happened over decades. or you had an old injury way back when, it's still haunting you today. And this needs to be managed. And so it's no longer maintenance care, it's management care. If they're going to get these flare-ups ongoing, it's supportive care. You try to intervene before that happens. But it's some kind of regular care that they get on. And if they are episodic, you want to get them at their episode, treat and release, that's fine. But if you know that, if you see a pattern coming, say, look, every 3 months, Brett, you're coming in here, your neck, quote, goes out, with that. So we're not going to do that. I'm going to see you in 6 weeks after you feel better. And we're going to try and postpone that. And if all of a sudden now you're going 6 months before that happens, we know it's working. You went from 3 months to 6 months, you're having your episodes. And then okay, let's find out what else. What other dysfunction? Maybe, whatever exercise I have to prescribe for you. We got to do an ergonomic assessment or get you a decent pillow. Okay, you haven't changed since you were in high school,
So you shouldn't have to apologize for that, in my opinion. I feel like we're always trying to defend that, but it always brings us to this philosophical question of when is your patient actually done? So when someone cuts their patient loose, let's just say, are we saying that they, all their joints are springing perfectly in 3 planes of motion? There's no trigger points in the soft tissues. There's no tension and tone in the muscles. Right. So and I always word it this way, would it be beneficial to see David Graeber every day of your life? It would be beneficial, but that doesn't mean that makes sense, right? So then with every patient, it's almost like you guys are kind of reconciling what actually makes sense for me to check in with you from a functional standpoint. And even Shirley Sarman, a physical therapist at WashU, Gray Cook, Annie O'Connor, these people that sometimes you wouldn't think that they would think that makes sense. Actually, what's wrong with having a checkup just to make sure that everything is, functionally moving the way that we want? But I feel like we've been pushed to now almost have to apologize that. So you're saying, okay, we're going to cut a patient loose, and now they might become an alcoholic. They're addicted to opioids. Wouldn't it be better off to see David Graeber than go down this dark pathway here?
Yeah.
And I just feel like that's a really weird thing. And students feel bad or they feel guilty because somebody's coming to see them. And I think that's insane, personally.
One of the problems with evidence-based practitioners is they're too smart. Seriously, they question everything. If you don't question it, you can easily have, by the way, there's two types of certainty. There's blind certainty, which is pathological, and then there's certainty. Oh, you really want to go there, right? But there's certainty, which allows saying, I know what I know, and I know that, and I'm really good at it, but I don't have a blind spot. I know that I'm still only looking at this, and there's a whole other world around here, and to be open to the fact that you're going to be exposed to something that knows that, I'm certain that I'm good. I'm also know that I have shortcomings, and that I'm not going to understand something, and I can't do this. I got to refer to him. I got to refer to you. I got to refer to a PT. I may even have to refer to a surgeon. So, we do what we can, but a lot of evidence-based practitioners really have
they're questioning themselves. So it's
because they're questioning, period.
Yeah.
Does this work? How can I make this work better? Is there a better way to do it? What would Brett Winchester do? What would Taylor do? And they're constantly looking good. Well, we've constantly questioned people. Now, this is different. Internally, people they don't pick up that you're questioning because you want to grow. They just pick up, maybe he's not certain. When someone comes in with blind certainty, just comes in and they're like, wow, he seems so confident. He seems so certain. He must know what he's doing. The person you want is somebody who's certain, they're confident, but they also know they got to keep growing and they have to keep learning.
But what if your son's cardiologist said, well, actually, I don't know if I'm going to be able to help this. We might be able to help your son with this valve problem, whatever it might be. Then all of a sudden you'd be like, I don't know if this is the right person for me or not. So I think with the people that are questioning, sometimes as you just said, that is getting the patient can pick up on that. Even if they're not admitting that, the patient is picking up on their uncertainty. So sometimes you need to go educate yourself to do whatever you can to get the certainty. If you're young, maybe fake it until you got it. But that's where I think these people get so good at their crafts because they've seen things so many times and they know what they can predict their outcomes. So then they can it's easier. They're not selling it at that point. They're just telling the patient, this is how it's going to go.
Right, they're not selling. They're telling them, this is what I know. You can fake it till you make it, but then you're still a fake. At some point, you either have to make it or you got to move on. Right. Let's be real. So I was thinking about this. Somebody was saying, well, how do I get this? I said, get a niche. Take 5 conditions and just learn those 5. And in fact, maybe even only treat those 5. And if somebody comes in and they're number 6, refer them out. Or just be honest with them. Just say, listen, I'm an expert at this. You have a lumbar facet surgeon, sacroiliac. I'm very, very good at thoracic local pain. Your migraine headaches, I don't have a lot of experience in it. I do get some results in it. I'm willing to work with you if you will. And you just be honest with them. And people, first of all, it floors people that they're like, oh wow, she's honest with you. What are you going to say? You're being honest with them. I could refer you out, but if they trust you, they'll say, you may not be the best person, but I trust you, I'm going to stay with you. Mm-hmm. And I've never had that not happen, by the way.
Or like in our field where we always have like arguments about different techniques and things like that, I think that, like to me, I have my auditing process with the patient, or we do, and that is joint play, trigger points, muscle length, functional testing, neurologic findings, deep tendon reflexes. Okay, so that's the playbook. So whatever technique you're doing, if you're not making a change there, then I think you got to question what you're doing. So to me, I think it's real simple to people who are kind of questioning their approach and things like that. Are you making a change in the auditing process? And if you're not making a change, then you probably need to reconsider what you're doing. And I mean, that's what we always work really hard to do, is like we're borrowing, stealing from all different technique systems in an attempt to see what is the best way and most effective way to change these audits. Right. Because that's the functional profile of the patient. When you walk into the treatment room, you have the subjective experience, but then you have the functional profile, and those don't always match up. Right. Sometimes like the pain is 100% better. This happens all the time. And the function, if you're honest with yourself, is the same. And the trajectory of that case, they're probably going to relapse quickly. Right. Or you have the opposite, where you have this shit glitter all over the case. The audits are moving perfectly, and then they're telling you they're no better. So what you've either exposed a chronic pain patient, or you've exposed somebody who's got a structural problem that you're not going to be able to get around. Mm-hmm. But the auditing process is so beautiful because it lets you know if the patient functionally is moving down. I think the patients too, they really appreciate that, because we've all had those patients where they're trying to tell you they're no better, but then you really question them, and then at the end they're like, actually, I think I am quite a bit better. It's like, right, exactly. Go to hell. Our day's not hard enough, and you're going to sit here and beat me down. But
I'm not any better. Well, look, you move like this, and now your shoulder's moving up here. It's like, oh yeah, that is doing better.
Yeah, but when I do this and I get some crazy,
I can't wash my back there still. I'm like, okay, all right.
Well, let's, as we kind of come to a close here, another passion of yours, Dave, is cervical spine. And so I know that that's something you love to teach on. Can you kind of give us a couple clinical pearls for manipulation of the cervical spine, or some of the things that you you hold to a high standard of when you're assessing and then eventually going to treat the cervical spine?
Technique-wise?
Sure, yeah, just technique, or maybe some of the audits like Brett was talking about with his cases, or
the elephant in the room. I mean, everyone's talking about vertebral artery dissection.
Yeah, don't over-rotate.
Yeah, period. Don't thrust in a rotation.
Yeah, it's not manipulation, it's the movement. I mean, if we really summarize it down, and does it really happen? Is it protopathic bias? I mean, that is the strongest evidence. It's overwhelming that they're walking in with it, and the train is already moving, and you're just jumping onto that. In most cases when that happens. So, but even good technique, don't over-rotate, don't over-extend, don't over-rotate. Doesn't mean don't rotate or don't extend, just don't over. I've seen. I know it's not moving, and then next thing you know, they're all the way over here, they're tractioning. It's like, don't do that. Respect the body.
Yeah.
Respect the body. Number one, all technique is feel. Once you put your hands on a patient, decapitate yourself. Stop thinking, go by feel. And all of a sudden, all parameters say do this, and technique says do that, but you know what? I just feel if I get this way, all of a sudden you feel that joint start to actually really, that's what it needs to do. That's worth locking out. That's where the fixation is. Yeah. And, go by feel, respect the body's parameters. Don't try and get a cavitation with every adjustment, especially the chronic, that they can only have this much movement. There's a lot that's got to be worked through before that joint can open up enough, especially if it's grossly arthritic, to have any type of cavitation. Don't try to rush Mother Nature. That goes back to what you were saying, is that's the other half of the coin, is let's say you have somebody who's really chronic, and that's a patient that's going to take a while before you could actually really get a good solid adjustment in it where you get some cavitation going. But you think, if I don't do that, I'm not doing anything, or I'm a lousy technician. It's like, no.
Well, they think that. I mean, I always use the analogy like, so like the students are learning how to adjust, and they're not very good at palpating, so they go home like on a break, and their family members want to work on them. They blow up some adjustment on them, and then they see their family member 2 days later, and the family member's like, hey, can you do what you did to me, 2 days ago? And because they don't know how to palpate, they do the adjustment and nothing happens. In a weird twist of irony, actually that's probably a good scenario. So basically the joint has restored its joint play and things like that. But the cavitation to the patient is so important. The patient actually thinks now that like, you're a buffoon, you've forgotten how to adjust in 2 days. Like there's actually, you don't know how to adjust me well now? And this actually happens to patients out in the wild in the practice too. So like you have to unplug yourself and liberate yourself from the cavitation, because there's cavitation. I mean, we can cavitate hypermobile joints or whatever. So explaining to the patient that manipulation is about restoring motion, not necessarily cavitation, that's vitally important. And then if you look at like Stu McGill and Kim Ross's research on cavitation, they found like in that paper that the cavitation was occurring like inches away from where the target was. Mm-hmm. The conclusion of the paper actually said that chiropractors are only specific 50% of the time. And so what I hate about that paper, I like certain things about that paper, but what it exposes is that cavitation can be occurring anywhere. The goal is not cavitation. The goal is better joint mobility. But that paper kind of led people to believe that we're not specific in what we're doing. The cavitation can be coming from, wherever.
You talking about Ross's paper?
Yeah, Kim Ross and Bresnik.
Thoracic.
Yeah,
exactly. Well, that's what we talk about, like research, to come to a conclusion that, cavitation, it's totally non-specific. That's a stretch. So you've just taken a real big leap to do that.
Right.
What was the Anderson Schneider's paper? They actually did the 3D cervical spine X-ray, and they showed, within three joints move when you adjust.
Right.
So you adjust C5, you're adjusting C5, C6, they're all cavitated. C6, 4, 5, they're all cavitated.
Right.
And he's shown that happens. So so it's not, quote, sniper specific, but that's only if you have a bone out of place concept, or I'm just moving C5 over. No, you actually mobilize a region, primarily the area you're contacting, hopefully, if you're good, and get it there. But maybe not, which is also good because that's a fail-safe. Let's say I found, C5 is where it needs to be fixated, but actually C6 is fixated. I put all my money on adjusting C5, but C6 releases anyway. I mean, so there's kind of a fail-safe that's built in there on the upside of the lack of specificity.
Yeah. I mean, if I put my hand across your back here, my hand's across 15 joints there. Yeah. So I don't know exactly, is it your costa transverse joint, your costa vertebral joint, your thoracic, who knows? But like all I know is the joints, that area is not moving well. Right. When I manipulate there, I'm improving whatever joint in that area is not moving well. Yeah. And I know that's not the sexy thing to say when you're a student because it's all about specificity, but that's the reality of it, whether people admit it or not. And that doesn't mean you're not being specific. That's what I think is,
That's true. Well, the thing is, the irony is you have to be specific in order to get those results, even if the results are non-specific or less specific with that.
It's good. I like that. You got to be specific to be non-specific, right?
Yeah.
Yeah, that's right.
Specifically.
Specifically, you got to be specific to be non-specific. So.
Sew that on a pillow. Yeah. Crochet that on a pillow.
Dave Graber. Well, beautiful. Well, Dave, I know you teach classes still and stuff like that. Is there any place that people can find you or anything along those lines that they want to learn from you?
I should remember my website. I have a blog which I update rarely, but it's Chiro Excellence at WordPress. I think it may be Dr. Graber at WordPress.com.
I'll find it.
If you're not following him on social media, like you're my biggest source for research. Like
Am I really?
You share research, and then I think with social media now, that's what I love about social media. It's like you'll highlight a paper, and it's so for the I think that's awesome.
It was Chiropractic Practice Research is a Facebook group. I started because I was doing all this research to get evidence-based, evidence-informed courses together. I said, man, I got all these papers. Somebody else should be actually enjoying this. And I was very, very, I'm not your generation, I'm very, very new at this. I need a platform to be able to store articles. So I said, I'll just throw it on Facebook. And all of a sudden, people were like, wow, this is great, this is great, this is great. I'm like, well, yeah, sure, I got something that's going to help you, it's going to help you. And then my goal was that everybody make that a kind of a conduit and a resource to keep dumping papers there so we can stay up to date.
That answers the question is, how do you stay up to date with research and practice? You find a good group or find a good person to follow, and the rest is history, right? And interpret it yourself. Actually read the papers and interpret themselves every once in a while.
You know, you do. You know, one of the things I did when I was doing this, I said, okay, I'm going to do a paper a week.
Yeah.
You know, that was my goal. I'm going to actually take a paper, not read the abstract conclusion, but actually go through it and see what do I understand, what do I not understand. If I don't understand something, who could I ask? And there's a number of people in the profession in that group. You could throw a question out, and they would love. Researchers, when you write for a paper, you write to researchers, they're like, you actually read my paper. They love it. And if you want to have a discussion with them, most will have a discussion with you with it. And even on social media, which is not the best place to have a conversation of any type, you know, as we all know.
That's right.
But you can do one-on-one. You can contact them individually. They love to do this. That's their love. That's what they're doing all day long.
Yeah.
And to find out that what they're doing is making a difference in practitioners. I mean,
why do you think there's such a gap on, like, okay, let's say you do actually read a good paper, and like, let's just say that the evidence is showing that if we do a Copenhagen exercise, that we can drastically reduce adductor injuries in soccer players, okay? So you read that paper, you're like, wow. But then, like, we all struggle with, like, implementing that into our, you know, like, you read it and it should just like, okay, well, let's just plug that in. Why do you think that occurs? I mean, because you read all these conclusions, you're like, well, shit, I should be doing this. But then, like, you fail to do it. Why do you think, I mean, why? You're so set in your ways, or you're...
Well, when they do studies, research takes on average about 17 years to actually get in to become standard practice. So if you do it in 17 months, you're way ahead of the curve that way. But yeah, we all have habits. Look, we don't sit around, we're not in a university setting where we sit around all day, oh, I'm going to just try that. No, you're running a practice, you're running a life, you deal with real patients, you've got a lot of other things you're doing. To take that particular, it takes time to actually implement it. Then you have to figure out how you're going to implement that. So part of it is translation. Okay, how do I make this work? Ideally, find somebody you could ask, maybe social media, anything else. Brett, have you found a way to, have you looked at this? You know, I have a material he's been doing it. He's been doing this. Share me, how are you doing this? How are you implementing this? Is it working? And that's probably the best way to actually do that. I mean, you got to translate. You got to take academic to clinical, and then the big league, clinical to patient. So actually, you don't start talking about, you know, I don't know, innate intelligence. You start talking about, you know, what it takes to actually get people better, and in a way that they can understand it as well.
Beautiful. What a great, good conversation, guys. It was fun listening to you guys riff. And Dave, thank you.
This is the loosest conversation, like formal, informal I've ever had.
That's the goal with this.
It's very cool. You guys do a great job.
Yeah, well, thank you, Dave. Well, I'll post a link to your website in the show notes, and I can't wait to see you next time, brother. Thanks for coming out and hanging out with us. All right, brother.
Yeah.
Good luck with patients, guys. We'll see you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.